So I'm going to jump right in and get started on measuring the adequacy of perfusion. And John, welcome again, and thank you so much for being here.
Good seeing you again.
Go ahead. I'm sorry?
Good seeing you again.
Yeah, I just appreciate you so very much. Okay, so it sounds like a simple thing to do, but in reality, measuring the adequacy of perfusion is really quite elusive. It's measured or assessed differently by many really excellent clinicians. There's a fairly wide spread of pressure acceptance, flow rates that are calculated and accepted. You know, I talk about flows, you go way back, and Dr. Shumway in California, at Stanford in California, in the early years, advocated for 30-30-30. That was 30 degrees, 30 degrees, 30 cc's per kilo of flow, and 30 millimeters of mercury pressure. That's 30-30-30. And he abandoned it because their neurologic outcomes were so horrible. So that ended that idea. It wasn't a good idea. Some people use pulsatile perfusion, some use continuous, and that's a big debate. Does pulsatile perfusion really create a physiologic pulse? And then when you look at the microcapillary circulation, the microcirculation, it's continuous flow at the capillary level. So do we really need a pulse to start with? So that debate has been raging on for a long time. Some people use vacuum assist venous drainage, others use kinetic energy, some use gravity. You have open systems, you have closed systems. You have temperature differences in drifting or cooling to 32 or cooling to 28. You know, for normal cases I'm referring to now, not necessarily, you know, deep hypothermia. Low flow states to facilitate visibility, how long that's tolerated for. The blood gases, we talked last night. John, you gave an excellent presentation on alpha stat and pH stat and how do we manage our blood gases. How much hypercarbia do we accept? Do we allow for that if we're doing TCD? Some measure, not TCD, NIRS, the cerebral oximetry. Do we use do we use it? Do we not use it? There's just so much variability. Electrolytes, where we'll accept our potassium to be. John, you were telling us about a situation where you had people freaking out because the potassium was 5.6. And, you know, I've taken people off pump with the potassium of 7 and was not concerned about it. So, you know, it's sort of amazing to me that they would get that exercised over a 5.6, but, you know, to me that's within normal limits. You have metabolites, of course, and we look at the hemoglobin, who accepts higher hemoglobins, lower hemoglobins, what's your transfusion threshold. We look at other hematologic reports. We consider coagulation. What did you do? 300 per kilo, 400 per kilo. You want your ACT above 360, 400, 480. I mean, there's such variability in how people who are really good at what they do and have really good outcomes conduct their cases. And it's always fascinated me at how we as individuals believe our way is absolutely the best. And everyone else is, how do your patients even live? But they do in a lot of different ways. There's a lot of different ways to do perfusion well. And I think really that's what makes it the art that it is. It's not an exact science by any stretch. And I think that when you consider artificial circulation and what it is we're really doing, a lot of the science, it makes sense in theory and mathematically, but doesn't always translate into actual physiology. So I just wanted to kind of throw out that initial set of thoughts. There's a very delicate balance. We need to do at the very minimum, the very bare minimum, because there's a whole bunch of other things. All of those things you see on the left side of your screen, in order to accomplish one thing, The reason we're there, the whole reason perfusion exists is to facilitate the surgeon's ability to do an operation. That's what the heart-lung machine was designed to do. But it's not just you turn the machine on and it runs. You got to do a whole bunch of stuff with that thing, because at the end of the day, it's not just facilitate the ability for the surgeon to do the operation. The patient has to be able to live and be able to remember who they are after the procedure is over. So, you really have to consider the complexity associated with doing something that seems relatively simple. We have one job: facilitate the ability to do the operation, I guess two, and not harm the patient in the process. So what humans tolerate in cardiac surgery is really remarkable. The durability of the human being is still to this day surprises me. But at the same time, we have this fragility. There's just, you reach a point, there's just a cutoff point, and that line is different for different people. But when you cross the line, it just really goes poorly. But up to the line, wherever that line may lie, it's remarkable at what we do. We go on bypass, and there's a lot of different ways to go on pump. Again, remember, everybody's got a different way, but it is not uncommon to open the venous line. The blood starts to rush back from the patient, displacing the prime in the line, or if you have a dry venous line, filling the venous line. Then it has to hit goes through the defoaming agent or area sock, and starts to fill the venous reservoir. Now, you have to have volume in that venous reservoir to start flowing. So you essentially are exsanguinating the patient. There's an acute exsanguination of the patient of several hundred cc's before you start flowing forward. Now you start flowing forward, and if you haven't mixed, you're going to have, 10, 15 seconds of just crystalloid going into the patient until the blood finally catches up and fills that line. That's why we used to mix back in the old days. John, did you ever mix?
No, I never did.
Yeah, we used to mix. We would take a little bit of venous blood and put a little arterial in, and take a little bit of venous blood and put a little arterial in. And we would do that until we became homogeneous. The pump circuit was homogeneous to the patient, and then we would initiate full bypass. And
Well,
it actually...
Well, you're saying you would drain a little bit of venous blood out, but give crystalloid into the arterial line? Is that what you're saying?
Yes, but it would be in small aliquots. So
right, so you're slowly diluting the patient.
Yes.
Instead of all at once.
Correct. Yes. It would take took about 3 to 5 minutes to get the process done.
I've not
But
heard that.
it really worked. It really worked. The place that I did it at.
Did you not have the drop of blood pressure when
Correct.
you went on?
That's right. We did not. That was what I was going to say, is that we would go on pump and you wouldn't see that big drop in mean arterial blood pressure until it finally will pick back up again.
Nice.
So we tolerate wide range of pressures. Pressure of 50, some places is where they keep it, 60, 80. Patient has any kind of carotid disease, they'll say, let's keep the mean at 90. But I show it in a slide later, but the normal mean arterial pressure is like 95. So it's not 60. Short-term shock from low flow periods is not uncommon when things happen and the surgeon needs the heart drained and can't see, and they need to turn the pump off. And we'll do that and we get nervous. Perfusionists start getting real nervous. We're like, it's been 10 seconds, it's been 15 seconds, and there's a clock running. But the patients tolerate it. And sometimes you have to do that repeatedly for a number of times to get the issue corrected. There's a loss of pulsatility. Does it really matter? You know, many studies demonstrate the disappearance of capillary beds during CPB, and I'm going to show you a video of that with either pulsatile or continuous flow. So, you know, is the loss of pulsatility the reason, or is it something else that's occurring with the extracorporeal circuit? Because it doesn't really come back with what pulsatile flow we're able to generate from the pump, which tells me really I think the pulsatility may be non-physiologic. That's what I believe, because I don't think the pulse pressure is wide enough and the upstroke is too slow and the downstroke is also too slow. So, but there are a lot of studies out there that demonstrate the disappearance of capillary beds during CPB regularly, which may mean that, yes, the capillary system may be continuous flow, and they have certainly kept a lot of cows and people alive with continuous flow systems, total artificial hearts, for long durations of time. They last a lot longer, and people seem to adapt to it. But in the short term, it's hard for me to say that it doesn't make sense. You need the pulsatile flow for our normal physiology to work, that something about the macrocirculation is connected to the microcirculation, and pulsatility has some relevance to that. I just, of course, really don't know. Acute dilutional anemia, we do that frequently. We take people that walk in with hematocrits of 36, and then the next thing you know, their hematocrit is 22. There's abnormal stimulation of baroreceptors and chemoreceptors. So we do all of this at a minimum. Again, there's many other things. When we put people on cardiopulmonary bypass, it's a lot to do to a human being. This is a slide that I wanted to put up, and what's important about this slide, and it didn't, the slide got messed up when it got sent over, but if you look over here, at least I can't see it. I don't know, can you see a shadowed area right here?
Yes.
You can? Okay.
Yep.
So within that shadowed area that you see there, that is where your cerebral blood flow is auto-regulated. When you get out of that to the right or to the left, you lose auto-regulation. So you can see that auto-regulation really goes away when you get a mean blood pressure of below 60. Once you have a cerebral perfusion pressure, which would be on pump what would be our mean arterial pressure. So, and I thought that was very important. This is a good slide to have so you can reference it and understand that the brain requires a perfusion pressure. And what I think is when you go on bypass, and we talked to Dr. Garami last night about the capillary opening pressure, or the cerebral blood flow opening pressure that's necessary, and you go on pump and your pressure drops to 30, and we're treating it, but it stays at 30 for a while, and then it comes to 40, and then it comes to 45 or 50. And if you remember what he was saying yesterday, is that they had to go up above 60, maybe even to 70, to get it to actually, that perfusion, the cerebral vasculature to open up and start allowing flow to continue to go through it in a homogeneous way using TCD as their guide. So when we come back up on flow and our pressure doesn't get up above 60, I think we need to start considering that's something we need to think about and say, maybe I need to bump it up. And then if they really want to bring it back down, we can bring it back down, but I need to make sure that I am opening the brain perfusion at that point in time. I wanted to show this slide. I thought this was a good slide. This was a fun slide. Let me turn my slides on over here. It's hard for me to see that far away. I'm getting old, John. Yeah, so this slide here endeavors to show where we have down here in the aortic. Here's the aortic chemoreceptors and the aortic baroreceptors. And so how many people, and I'm assuming you've seen it, John, have given a dose of cardioplegia, and as you're giving the cardioplegia, you have the root pressure is really going up, and then the next thing you know, your systemic pressure is going down. How many times have you seen? I've seen that a lot.
Oh, absolutely. The cardioplegia gets into the system and causes vasodilatation.
Yeah, no, that's the second thing. But I think too, it is a baroreceptor, that you're increasing that pressure in that aortic root, and it's sensing that and vasodilating. Then you have the potassium on top of it that then kicks in. But I think, at least I think, the initial cause of that are these baroreceptors, but also the chemoreceptors. And I think that, a lot of people, even though we were taught this a long time ago, I think we've sort of forget that happens. And it's almost predictable, really.
Mm-hmm.
So what this video is going to show you, this is the actual microcirculation of a case that I was doing with one of my colleagues. And it starts off with they're cannulated, they're ready to go on pump, and then I'll tell you when they go on pump, but I'm not going to have to tell you. You're going to be able to see. Now, I took a screenshot of what we had done, so you see this right here. I'm going to be moving that around in order to, or this one here. One of them, I'm going to be moving around to point stuff out, but that's from a different monitor. But this is the microcirculation here, these very small vessels that you see. This is the capillary system. These big vessels that you see here are predominantly venules. So what you want to see is you want to look at these small vessels that you see here. These are the ones that really matter. All right? So I'm going to turn it on and run it, and I'll tell you when we go on pump. Did I need to tell you? Or did you see it yourself? Did you see what happened there, John?
Well, it looked like you had a nice steady flow in the capillaries, and suddenly it became very irregular and sporadic and inconsistent compared to how it was prior.
And then what else do you notice about that in terms of the capillary density? How many of these little small vessels that you're able to see? Because what you see running through there are individual cells. That's how this camera works. You're looking literally at individual cells.
It appears to me as though about half of them are no longer perfusing. Like you've had a lot of capillary collapse.
Absolutely.
Especially there in the lower center of the screen.
Absolutely, yes, absolutely. And I think that is the whole point of this, is when we go on pump, and I hate saying this because you know how much I hate off-pump CABG surgery, but when you go on pump, this is very common. You can go back and look through various studies that exist, but I did it myself on a couple of patients and have the camera, in fact. So I'm going to do it on some more once this COVID nonsense is over with. It's a lot of the fun things I wanted to do have been a little bit derailed because of what's been going on. But it's truly remarkable at what the effect of cardiopulmonary bypass is on the capillary system. Now, I kept this running. We ran it again. I didn't see it come back. I didn't see it come back for the duration of the pump run. So at first I thought, well, maybe it's just we're going on pump, we're getting a saline blast or an isolite or plasmalite blast, and so there's no blood. But then think about that. We're flowing non-heme directly into the brain. Maybe that's not such a good idea for a period of time. Maybe we should go back to mixing. But my point is that it never recovered until after termination of bypass and restoration of native circulation with pulsatile flow. We even tried pulsing on the pump. There was no difference. So I don't want to just show a bunch of videos, but it was really, really remarkable. And I would love to do a big study on this. I think it would be fascinating. I just need to find a place that is, you know, more academic. I live and work in more of a community environment, but it would be a fantastic bit of information that we could get, and would be, I think one of those sentinel trials or sentinel studies that would really demonstrate things, because we could try different things to see if it reduces that phenomenon. So some understood parameters. I think everybody, you know, there are some places that run their means about 50, but, you know, really I think most places are between 60 and 90. Normal is 80 to 95. So when we run at 60 or we run at 70, we're still 10 millimeters under. And think about a patient who has undiagnosed or untreated hypertension. You know, how much are we increasing that patient's risk to acute kidney injury? We work really hard, I think, at keeping the acid-base balance as physiologic as possible within some, you know, ranges. We frequently manage hyperkalemia, especially when you give a lot of potassium, a lot of cardioplegia. We give lots of sodium. That's something we give a lot of. Dilutional acidosis is not uncommon. We dilute out the bicarb when we use all of these crystalloids that are not bicarb based. All of our fluids, even though they're pH adjusted with acetate. So you dilute out when you're doing, let's say you have a K of 7 and you want to do CVVH on the pump. You run a hemoconcentrator, you pull off a liter, give a liter, pull off a liter, give a liter. You're diluting the bicarb. You're going to have to give bicarb. We've all seen that happen, I don't know how many times. So, you know, that and that kind of a sodium load really isn't that good for you either, and we have to consider that. And then it is very uncommon, we've talked about it, I think you and I, it's not common in our practice, and I don't think it's that common around the country. I've been a lot of places, talked to a lot of people, to measure lactates routinely on pump. And I'm going to show you something which I think is, you know, important, because I'm kind of going somewhere with this, with a recommendation or a suggestion. Okay, so the body in all its complexity is really all about DO2, delivering oxygen to the tissue. We got to have it. Oxygen, or DO2, is another one of those obvious items we don't routinely measure, though it is extremely easy to calculate. The normal adult male runs about 950 mLs per minute, and the range for normal is between 750 and 1200 mLs per minute. But what's important is down here. And if you look at the side on the right, okay, the side of the curve is the normal state. Cellular consumption, VO2 is consumption, is independent of DO2. These cells depend on aerobic metabolism, we're familiar with that, and are not producing lactate. Moving leftward, as we go from here and we move leftward down the scale right here, we reach this point called critical DO2. When your DO2 has reduced to this level, which is the critical DO2, you are now, your cellular consumption is dependent on DO2. Cells would consume more oxygen, but there is no more being delivered, and these cells now have to depend on anaerobic metabolism, which produces lactate, and eventually, of course, untreated, they will die. So measuring lactate is now exclusively, there are always going to be some exceptions, I'll accept that, but by and large, if you're on bypass and you don't have some other phenomenon occurring where you have ischemia to a particular site that's not being perfused at all and coming back, you have no return from it, so you may not see that lactate, it may be severely delayed. Generally speaking, if you are not producing lactate, you are providing the patient with sufficient oxygen. If we measure DO2 and we know based on the patient's age, sex, weight, what their DO2 needs, body habitus. Is it muscular? Are they fat? What is it? Skinny. We know what their DO2 needs to be. And if we're anywhere within that range, we're going to have luxurious perfusion. And there's a reason I say that. Not just good perfusion, luxurious perfusion, because there's other factors that are involved here. This slide I thought was very good at explaining all of this. If you look at the green line, you see that is your DO2. And you going from left to right, you can see it decreasing, but not just decreasing rapidly. It is simply decreasing. You look at the red line, and that is your arterial saturation up at the top, going from about 90% down to about 82%. But look at your purple line. That's the one that really matters. That's your oxygen extraction rate. And you can see as your DO2 decreases, your oxygen extraction rate starts to climb very rapidly. And if you look at the blue line, your SVO2 starts to fall almost as rapidly. So your O2 extraction rate is a very important thing to look at. The difference between the two are your oxygen extraction ratio, is a ratio of the body's oxygen consumption compared to the systemic organ delivery, or your DO2. So it is a ratio. Nevertheless, this is also a very good slide. And what you see here is, if you look, okay, here is your oxygen delivery going from low to high. Here is your oxygen consumption going from high to low. Here is your oxygen extraction ratio going from low to high. And here is your SVO2 going from low to high. And if you look at the intersection of the critical DO2, you see your lactates go well, and then boom, they start to climb, and they climb very quickly. Lactates will climb in correlation with your oxygen extraction ratio once that oxygen extraction ratio reaches the critical DO2. So a little more detail about oxygen consumption and the oxygen extraction ratio. The normal is about 0.2 to 0.3, which corresponds to an SVO2 of 70 to 80%. A high O2 extraction ratio, which means a low SVO2, is a feature of flow insufficiency. So you basically have a shock situation or low flow for any particular length of time. Anything that causes a decrease in cardiac output or an increased tissue oxygen demand. So you have to remember that. The oxygen extraction ratio, therefore, your SVO2, will be affected by not only low flow, but also increases or decreases in metabolic demand. A low extraction ratio, on the other hand, results in a high SVO2 and demonstrates either a diminished tissue oxygen demand or ineffective oxygen utilization by the tissues, or some sort of pathologically increased cardiac output, like just a very hyperdynamic cardiac output, which you sometimes see in sepsis, but well in excess of the body's physiologic requirements. Now, I'm going to tell you a case. I like telling cases. I love telling stories about cases, John. And if anybody can get this right, I'm going to ask a question. And if anyone out there can call in, put the number up, call in with the answer. I'm not going to say anything until after it's over. So I'm going to give you about 10 minutes. So there was a patient, and the patients, they were on ECMO, they were on VA ECMO. The arterial PO2 and saturation, well, PO2, and we'll just say in this case, PO2 coming out of the oxygenator was essentially the same. It was only 50 it was like 350, and the PO2 coming back from the venous line, venous access line, which was in the right atrium, was 300. If anybody can tell me why, and basically the blood gases were identical, but yet this was in the femoral artery, and there is no doubt it was in the femoral artery. That's indisputable. So we have to stipulate it was in the femoral artery. It's not a trick. The venous line was in the femoral vein into the right atrium. Absolutely cannulated perfectly anatomically. But for all intents and purposes, the blood gases coming out of the oxygenator and the blood gases coming out of the venous line were essentially identical. So you got about 10 minutes while I wrap up my talk, and anybody can get that answer. You get one of these fashionable perf web cups. Y'all have seen them. People are using them now as collector items. So if you got the answer, call in. So what are some of the factors that increase oxygen consumption? Well, surgery itself. You can see the list, but I highlighted a couple. Inflammation, because these are things that we're involved in. We're doing surgery. We're controlled trauma. Inflammation is going to occur from sternotomy, from going on pump, all that stuff, and adrenergic drugs. We give a lot of those, right? Factors, however, that decrease oxygen consumption: sedation and analgesics, paralytic agents, shock and hypovolemia, hypothermia, mechanical ventilation, and antipyretics, all of which we use. So when you look at the oxygen consumption of a patient that should be between 900 or 850 and 1200, that's for somebody who's standing up like I am, not the patient lying on the bed, asleep, paralyzed, on the anesthesia ventilator. You got to remember that. Now, some things we do to them may cause a little bit of uptick in that, but by and large, our oxygen consumption, our oxygen requirements are going to go down. But how far down, is really the question. An abnormally high extraction rate occurs during anemia. Well, we cause anemia. Of course, there's a debate. What's really anemia? Is 21 really anemia? Is 18 really anemia? Is under 30 really anemia? Those are different topics for different days, but there's wide variability, and I think a lot of debate that still rages to this day as to where a hematocrit should be on most patients and then certain patients. I think it needs to be individualized. A young, healthy 22-year-old that, let's say, got stabbed in the chest and needed to be put on bypass probably would get that hole fixed, come off bypass with a crit of 16, and probably do okay. More than likely, good chance they would not need a transfusion, I think, and do fine. Even though I think they would get one in most institutions, I think they could get away with that. But you take a 65-year-old diabetic, hypertensive, heart failure grandmom that you do a mitral valve and 3 bypasses, 3 jumps on, and you try to do that to her, or 18, even 21, it's a whole different ballgame. So when you have a low extraction oxygen ratio, low oxygen extraction ratio, one of the things that causes that is artificial circulation, interestingly enough. So I thought that was very interesting. And they say on the heading that it's from increased oxygen delivery. So I'm assuming that's VA or is it VV. So I think that if you are on artificial circulation, such as ECMO, for a reason of having a hypoxic episode, and you're able to improve that with normal cardiac function, you're going to have a lower oxygen extraction ratio because you now have luxurious flow and oxygenation. The theoretical rationale for clinical use of oxygen extraction ratio may be used to assess flow insufficiency in critically ill patients. Look, I contend every patient that goes on cardiopulmonary bypass is critically ill for a period of time. Hands down, that's my belief. There is some evidence that high O2 extraction is associated with lactic acidosis, suggesting that it could be useful as a global index of tissue oxygen delivery. Shock is defined as inadequate oxygen delivery, or DO2. Thus, the oxygen extraction ratio should theoretically be a perfect representation for the magnitude of shock. However, lactate is a very easy test to run. So why don't we just run it? Why is lactate not routinely sampled on our pump blood gases? It is if you use like some of the point of care devices, they'll have lactate already built in, but most people never look at the lactate. And I know a lot of people that don't have it on their device and don't ask for it. But it's a perfect way to assess, am I delivering sufficient oxygen to this patient's tissue? Without all that other stuff that I just went through with oxygen extraction ratios and calculating O to VO2 and doing all of that stuff. All you gotta do is just run a lactate. The lactate's normal, you're providing plenty of oxygen to that patient's tissues. So what I did was I took this patient and I calculated their DO2. 62-year-old female, 162 centimeters, hemoglobin of 13.6, cardiac output of 4.8 liters a minute, and that's going to provide that patient with a DO2 of 728 milliliters per minute. Go on pump with 1,000 cc's of prime plus 750 of anesthesia volume and a flow of 3.8, your DO2 is dropped to 412 mLs per minute. Now, is that enough? Patient is under general anesthesia. The patient is paralyzed. The patient's on mechanical respiration. So their consumption of oxygen has gone way down. And then we haven't even considered temperature. Are we going to drift? Are we going to cool? What are we going to do? So you look at this graph here, and we all know this formula. In case you didn't remember it, it's 7% reduction in metabolic requirement for every 1 degree drop in temperature. Now you look here at this graph, and let's see if I can get this thing to work. There it is. I can't ever find it. There it is. 37 degrees, you're at 100%. But when you go way down here to 30 degrees, I didn't go too far, I just went to 30 degrees. You're at 60%. So that patient who was at 414 was at 56% of baseline. If they were at 30 degrees, without taking into consideration all the other factors that I have already previously mentioned and articulated that have reduced their oxygen consumption, their oxygen demand, that's plenty of flow for that patient, which can be validated by checking the lactate. I think you see where I'm going with this. My theme today is we need to check the lactate. Follow the lactate. Okay, so since I put the old phone booths in there, just because I feel that way sometimes. I'm feeling that way after these 2 weeks, and I'm feeling that way after this COVID disaster. Every television program I watch, every advertisement I watch has to do with COVID. Everybody, that's all they talk about is COVID, 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 COVID. And we ended up calling this the Corona 30, but it really is the Corona Beer 30. It has nothing to do with COVID. But the phone lines are open if anybody would like to ask anything, if anybody has an answer to that question. And again, you can have that stylish Perf Web cup. You've seen them on here before. They're really nice. Great to have coffee or cappuccino in, something more sophisticated, because we're kind of sophisticated around here. John, you have any ideas?
I do know one thing that will cause that, and I do know a theoretical second thing that would cause that. I don't believe, however, that either one of my answers is probably what you're looking for.
Well, that's what I'm looking for. It's what it was. I'm not looking for anything. I know what caused it.
Yeah, well, I'm saying whatever really caused it, I don't necessarily know if my ideas are going to be that, but I do know one that will give you exactly what you're talking about. You want to hear it?
Say it. No one's called in yet.
I've seen this several times. If you're on ECMO and you're on VA ECMO, like you said you were, and everything's fine with the cannulas, when the patient is
wait. Somebody's calling.
Okay.
Did they call? Oh, what did they disconnect for? Okay, wait, John. Wait. I gotta see. I already sent. I already owe you like 3 cups.
No, I don't. I have enough cups. I have a 6-pack of cups.
Can you call them back, Magic?
So I'll bring up a different topic if you want while the caller's calling back.
No, it's some overseas. I don't.
Somebody overseas? Oh, okay. Try to call back. We missed your call.
I'll bring up a different topic for a minute while we're waiting on that caller. You were talking about all the different things that you said we have one real job, or maybe 2 jobs. One is to make so the surgeon can do his job or her job, and the other is to keep the brain alive and the rest of the body.
Yeah.
Really, that's really our 2 jobs.
Right.
But, if you look at, and then you listed all the different things that are going on that we have to worry about, this has been done. If you look at...
Answer. Sorry, John.
Yeah, it's good.
Hello, you're on the air.
Hi, good afternoon. I'm Karen.
Hi, it's nice to see you.
Hi, how are you?
Good, great.
Yes.
Where are you calling from?
I'm calling right now from Colombia, but I am from Venezuela. I'm having a good time with your talk today.
Thank you.
I would like to answer. I don't do ECMO procedures, but I read a little bit. Maybe the answer that the same PO2 from the venous return, it's because the patient has a natural septal defect, maybe?
A dissection?
No.
That's a good thought.
She said atrial septal defect.
An atrial septal defect? Oh, that's a good thought too. But no, that's not the reason for this. No, but that's a good thought.
What?
That was a good thought.
Wow.
You stay on the line with us. Hey, listen, you need to put our email address up. What's your name, ma'am?
Okay.
What's your name?
Okay, my name is Karen Pertus.
Karen, oh, okay, I saw you on the YouTube. Look, send us
on the chat.
Yes, send us an email if you would at contact right there. We just put it up. Send me an email because we're gonna send you a cup anyway.
Okay. I will send
but
you
stay on the line with us if you'd like. I'll tell you what happened.
Okay.
John, what were your thoughts?
Well, I can tell you one thing that does cause this. On ECMO, because I've seen it twice. If the patient is 100% deceased and you still have the patient on ECMO, your venous blood gases will be almost identical to your arterial blood gas.
No, you are correct. So, Karen, the answer, John got the answer correct.
Oh, did I?
The patient had
I
zero.
didn't think that was going to be it.
Yeah, that was it. The patient had 0 oxygen extraction.
Correct.
Because the patient was deceased and on ECMO. So they had blood flowing through their blood vessels, but there was no metabolism going on anywhere. And
the flow is excessive.
it was horrible. It was horrible. But look, we need your address at that email address so that we can send you a cup, certainly, because we want to do that. So what hospital do you work at?
I am from Hospital Cardiológico in Venezuela. Yes.
Very nice. And how many cases are y'all doing down there?
Well, right now there is no surgical activity because of the crisis, the sanitary crisis. So, but we are a big hospital. Sadly, we do not perform the most of the cases we would like to because of the economical situation of my country. But we are a good hospital.
Yes.
With good people.
I have no doubt. And you said you don't do ECMO there?
No, we don't. We don't. At this moment, we don't. Only cardiac surgery, but without ECMO.
Do you see patients that you think might benefit from ECMO where you are?
Sorry?
Do you think that there are patients that would benefit from ECMO where you work?
Oh yes, absolutely. But at this moment, from a long time from until now, there are no performing complex cases. Only low complexity cases.
Yes.
But sure, I have no doubt that the ECMO is imperative to have the availability in this kind of hospital, of course.
Yes, of course, I understand that. Do you mind if I ask where you trained?
I trained in Venezuela, in Hospital Universitario de Caracas.
Oh, very nice. In Caracas, yeah. And then how long have you been a perfusionist?
I've been perfusionist for about 19 years.
Wow.
I graduated in 2001.
Wow.
Yes.
That's a long. That's a lifetime. You sound too young to have been a perfusionist that long, and you almost seem too nice. Most 20-year perfusionists are never really nice.
Yes, it's my life, I think. But 2001 was a different economical, political era in my country, but we take advantage of that at that time. But sadly now it's pretty much different. So.
I understand. Well, it'll get, you know what, it'll get better, Karen. It will get better.
Well, thank you. Thank you. I appreciate your sessions and your knowledge. I am taking notes.
Well, thank you so much, too. We're looking forward to communicating with you via email, and maybe one day we'll come down and visit.
Thank you.
Bye-bye.
Okay, thank you.
Bye-bye.
Bye. Good afternoon. Keep going.
Ciao. Okay. Where's John? Oh, he left? Oh, okay. That was good. That was really nice. It was nice to hear from Karen from from Venezuela, but calling from Colombia. She may be on vacation or something, I'm assuming. I didn't ask that. But Karen, don't forget, send us an email. Okay, so do you want to take just a brief break? And why don't we do that? Don't do the whole thing. Just put up the thing that you put up, and we'll just wait for John to get back and then dive right into his talk. So we're going to take just a short break, but we're not going to play commercials. We're just going to go to a certain screen. And everybody just hang on and be patient with us. Thanks.